We will try and get to all of them. And if you are severe or it's hard for you to look at a screen for a long period of time and wait for your question, we are recording. So don't worry if you need to step away after asking. We have one first question from the community. Are we seeing chronic migraine, particularly in young women and girls with long COVID? And what treatments does CORE suggest in cases of chronic migraine?
Okay, that is a great question. And yes, we are seeing chronic migraine in people with long COVID. And yes, we actually do see a little bit of a preference for women and young girls to be experiencing chronic migraine. We do think that the reason for this is hormone related, and that hormones of ovulation can influence the cause of the migraines. When it comes to what to do about migraines, it really does come down to what is driving the migraines. Often we can see that neuroinflammation, maybe even autoimmunity, might be driving those migraines, and so individuals have had good responses to medications that reduce systemic inflammation, as well as address other interventions that can address autoimmunity, things such as IVIG. We've also seen that some people get migraines due to blood pressure fluctuations from POTS. So in that case, POTS is postural orthostatic tachycardia syndrome, which happens sometimes when a part of our nervous system called the autonomic nervous system is unable to help us maintain stable blood pressure and heart rate when we're changing positions, going from laying down to sitting to standing. In cases where migraines are being caused by POTS, medications that can help to stabilize blood pressure, things like pushing IV fluids that can help with maintaining blood volume. These are all things that can really help folks with migraines. Similarly, individuals who are getting migraines as a result of hormonal dysfunction can often benefit strongly from things like hormone replacement therapy, working with an endocrinologist or a migraine specialist who has knowledge of hormonal causes of migraines.
Do you guys look at mold toxicity?
Mold toxicity and other environmental exposures, things like heavy metals, are absolutely, we think, one of the drivers of symptoms in infection-associated chronic conditions and illnesses, things like long COVID, ME/CFS, chronic tick and vector-borne illness. Because we are an insurance-based clinic, and it's challenging for us it's not challenging for us. We don't necessarily want people to walk away from our clinic with a huge bill. We don't routinely test for mold in every single patient, but what our protocol is to really dig into people's symptoms and really actually ask the question about whether or not location influences symptoms. So often one of our first clues that mold might be at play is when somebody says, I've got these terrible symptoms, but when I leave the house, and if I stay at a friend's house or if I go to a hotel, all of my symptoms go away. When we hear about things like that happening quite routinely, that gives us a clue to test for mold. And we will then recommend really well-validated, third-party tested platforms like real-time labs, and get mold testing done. It is a little bit expensive, and unfortunately insurance doesn't cover it, but because it can be such a significant driver of symptoms, we won't overlook it.
What blood tests and diagnostic tests do you recommend patients get to see if symptoms are actually from long COVID as opposed to some other disease process?
So rather than thinking about specific blood tests, which, I think that blood biomarkers are coming along nicely. I think, many people in this community are probably seeing what I'm seeing in terms of
what blood tests and diagnostic tests do you recommend patients get to see if symptoms are actually from long COVID as opposed to some other disease process?
So rather than thinking about specific blood tests, which, I think that blood biomarkers are coming along nicely. I think, many people in this community are probably seeing what I'm seeing in terms of groups like Atomarker, groups like Infecto Labs that are starting to do some really interesting long COVID specific blood biomarkers. And we're watching those. They're not yet FDA approved, and they're not yet, you know, where we need them to be fully covered by insurance, but we're watching the work that's happening right now. But rather than relying on blood tests that aren't yet perfectly validated, what we tend to do is listen to the patients who are telling us about their symptoms. So we will do things, we're taking a good subjective history of understanding when symptoms began, what our patients think were the driving cause of the symptoms. And, when we're talking about long COVID specifically, what we try to do in diagnosing long COVID is to try and understand how we can link long COVID symptoms to an initial SARS-CoV-2 infection. So when somebody says to us, listen, I have these very complex symptoms, I've got pain, I've got cognitive impairment, I've got extreme fatigue, and those symptoms didn't start until they had a SARS-CoV-2 infection that they failed to recover from, that's a very good chance, according to the CDC, National Academies of Science, Engineering, and Medicine, and the World Health Organization, that we're going to be dealing with a long COVID case. Now, of course, we do comprehensive testing to rule out other drivers of the symptoms. So we try and understand, is there anything else that is very obvious that could be causing these symptoms that is not long COVID related? An example of that might be individuals who come to us and say that they can no longer tolerate exercising and they experience cardiac arrhythmia. Well, we're going to do an EKG and an echocardiogram to look for structural heart problems that may have predated their COVID infection that are not related to long COVID. But in general, diagnosis right now has to come from carefully evaluating each patient and listening to their clinical history. Yes, I think vaccine injury is something that we're taking extremely seriously, and it is something that we see at the clinic, and our clinicians are working with patients who do have vaccine injury. We are hoping that some of the really exciting developments in monoclonal therapies, these are therapies that really target persistent antigen in the body, including spike protein. So some of the work that I presented at the most recent NIH Recover TLC meeting, where we were talking about a company called Invivyd that has produced a new monoclonal called VYD 2311. We're really excited about the potential for that in treating vaccine injury because it has a robust ability to remove spike protein from the body. So we're hoping for some new therapies shortly, but in the meantime, it is a very real condition, and it's something that we aim to treat.
Can those of us based in the Global South access experts at Core Sinai remotely? We are suffering with long COVID, and there isn't anything where I am in India. I was this healthy young person and am bedbound.
I'm so sorry to hear that, and we understand the frustration and the challenges with accessing care outside of the United States. We do our best to respond to requests to have conversations with clinicians who are local to you. Right now, it's very challenging for us to treat people outside of the United States because our providers are unable to prescribe outside of the state of New York. So we can't prescribe medicines, and it's very difficult for our providers also to see people outside of the state of New York without charging a lot of money, which is something that we don't want to do. We want to always be doing what we can to be seeing patients through insurance, because we believe that that's the only model that is going to be sustainable enough for the tens of millions of people suffering with long COVID in the United States, if not the hundreds of millions outside of the United States, to be seen. But we are always willing to have conversations with local providers and share our knowledge, and also to share our manual that is freely available on our website, which really walks through all of the testing and treatment procedures that we offer at the core.
Is long COVID fatigue actually ME/CFS?
So I think when it comes to distinguishing between long COVID and ME/CFS, um, we tend to think more about the question of what are the things that are driving the symptoms that are affecting the patient in front of us. So rather than focusing too much on the diagnosis, we're really interested in phenotyping, which is a fancy word of saying narrowing down exactly what might be causing the symptoms that someone is experiencing. For instance, regardless of whether you have an ME/CFS diagnosis from before 2020 or a long COVID diagnosis after 2020, or someone who has been diagnosed with both long COVID and ME/CFS, if you come to me and say that your most severe symptom is fatigue, what is most important from a clinical standpoint is for your provider to understand why you have fatigue. Do you have fatigue because you have persistent SARS-CoV-2 virus in your body? If that is the case, we need targeted antivirals or targeted monoclonals, or perhaps both, to address persistent SARS-CoV-2 in your body. If you have fatigue because of autonomic nervous system dysfunction, regardless of whether you have long COVID, ME/CFS, or both diagnoses, the intervention for autonomic nervous system dysfunction is going to be similar. And it's going to be informed based on how your blood pressure fluctuates, how your heart rate fluctuates, and what the other results of your autonomic testing show us as to which medications or which treatment approaches that we'll be using. So something that we always advocate for when we're managing infection-associated chronic conditions and illnesses is to look beyond the initial diagnosis and really try and understand what are the root cause drivers of the symptoms that are being described, as opposed to fixating too closely on the diagnosis.
Do you believe most people suffering from long COVID will ultimately get better?
I think at this point, it's always hard to predict what's going to happen in the future. But I do believe with all of the research going on that we are getting better and better at managing long COVID every step of the way. And, in 2020, when people were asking me the question about how well are we doing in treating long COVID, we only had a few tools. And what I could promise people is that we could make most people feel a little bit better, but the number of people that were being quote unquote cured was very, very small. Now that we've fast forwarded, about 4 or 5 years, I can say that we do have a lot of people who are going into remission. We don't know if their symptoms will come back, but we do have a larger proportion of people who are saying, you know what, I feel better. And that's because we have a larger bag of tricks. We now have combination antivirals that we're trialing. We now have wearable devices that can address neuroinflammation. We now have all sorts of different combinations of supplements and medications that really seem to be moving the needle on symptoms. So the question of whether a majority of people will be cured is a hard one to answer. But I do believe that if the research continues to move in the direction we've seen over the last 5 years, the majority of people one day will be able to manage their symptoms to a point where even if we can't cure long COVID, we can at least manage it to the extent that the symptoms do not interfere with daily life, so long as we have the right combination of medications and treatments managing those symptoms.
Are you seeing any research going on about guidance for vaccines with long COVID patients? I'm aware of the general advice of if you want to get Novavax, but that it remains a crapshoot for symptom shifts.
Yeah, this is a great question, and unfortunately, you know, research into vaccine use in general has just been really hard to conduct. I think very transparently, our team has received a lot of online criticism and online pressure around the work that we have already done with really wonderful collaborators like Akiko Iwasaki and Harlan Krumholz from Yale University. And it is work that we continue to do so that we can give folks answers exactly on this front. However, right now there isn't a whole lot of great guidance on the use of vaccines in folks who have long COVID. We have noted anecdotally that individuals with long COVID are far more likely to experience negative effects from an mRNA vaccine. So, I know that the person who posted this is already onto what I'm about to say next, which is non-mRNA based COVID vaccines such as Novavax seem to have a lesser chance of triggering symptom flares. But right now, that's the best guidance that we have, and that guidance is based on anecdote and experience as opposed to real world data, which is really unfortunate because I wish that we did have studies and data to point to.
What is considered a high level for the SARS-CoV-2 spike antibody lab value from LabCorp? And have you seen a correlation of high levels and significant symptoms or the reverse?
This is a great question. And in terms of what is considered high, unfortunately, we don't have solid research that is pointing us in the direction of being able to interpret this in a very quantitative way. What I can say is typically what sort of raises eyebrows with providers in our clinic will tend to be antibody levels that are coming over 1,000, 1,500 on that particular test. That indicates that somebody is producing, a lot of antibodies for SARS-CoV-2 antigen, way more than something that we would expect in the sort of like low hundreds for someone who's having sort of like a mild antibody reaction to SARS-CoV-2 antigen. There has not yet been literature showing us that individuals with higher and higher and higher spike antibody levels seems to correlate with symptom severity. And interestingly, and what I think is an interesting point to talk about is that in the few monoclonal antibody studies that have been conducted by folks like Professor Andrew Shaw in the UK and Michael Peluso and his wonderful team at UCSF, what we have seen is this tendency for folks who have lower antibodies against SARS-CoV-2 antigen seem to be more likely to respond to monoclonals, indicating that somebody who has viral persistence, who is not able to mount a strong immune response to that persistence, may be more likely to respond to a monoclonal antibody. And people who have very high counts may respond better to things like plasmapheresis, IVIG, so things that are calming the immune response down a little bit and taking some of these things out of the blood. So this is still very early, but this is the best answer that we currently have for how to respond and think about some of these antibody results.
Are there any trials wrapping soon with data available?
Yes, our Humanity Neurotech clinical trial, which is a first-in-human clinical trial of a novel device that uses a technique called microtesla magnetic therapy to address neuroinflammation in the brain and hopefully address cognitive impairment. We are into our final participants right now. So we actually think at last count, I think our final participant enrolled in this trial will be done in about 5 or 6 weeks. And so if we have about a month after that for data analysis, we hope to be unblinded and releasing the results of that trial. We've been very, very excited about this because it's such a novel device and a really unique approach on addressing long COVID related cognitive impairment, which is such a debilitating symptom for a lot of people. Our antiviral clinical trial, where we're looking at Maraviroc and Truvada as potential interventions for long COVID, as well as our low-dose rapamycin trial, we're hoping that we'll be able to wrap up in about Q2 of 2026.
Are we still enrolling for those?
We are still enrolling for both of those trials. Thank you very much for bringing that up. And anyone who is in the New York area who can participate, please reach out to our core research team, which is just coreresearch@mountsinai.org.
There is a link in our bio to sign up for each trial. Will CORE be doing any trials of monoclonal antibody therapies?
Great question. We are working really hard with Invivyd to gear up for a VYD 2311, which is their newest monoclonal. If you're interested, I spoke in length about this clinical trial at the Recover TLC meeting that was a couple of months ago, and I'm sure we can actually probably find that recording, which is available on the NIH website, and make some stories about that. Thank you. But yes, the answer is yes. It's a very exciting monoclonal. It is more potent than any monoclonal and more broad spectrum than any other monoclonal that has been used previously. And we're hoping to run a clinical trial as soon as Q1 of 2026.
Will there be any upcoming decentralized trials where you can participate from home, and what's that timing?
Yes. Well, in fact, the monoclonal trial so the decision to decentralize a clinical trial often comes down to availability of funds for the study sponsor. They are more expensive. We always aggressively argue for decentralization of trials because we believe that it makes the trial go much faster. So even though there's a larger upfront cost, if you're a drug company, we actually get to recruiting patients much, much faster because it's more convenient for people to participate, which means that more people can participate. So we will be strongly advocating for the monoclonal trial to be decentralized because we really do believe that it is a more efficient and appropriate way of running clinical trials. But unfortunately, it is always subject to the availability of funding. It's something that we advocate for all new trials, and if we can afford it, we do work to make it happen.
How do you differentiate from chronic Lyme, long COVID, and vax injury?
Yeah, so our guidance on differentiating between those diagnoses is really to try to link it back to the triggering event. So did you start feeling sick, chronically ill, after you experienced a SARS-CoV-2 infection? Was it after exposure to an mRNA vaccine or any other, form of SARS-CoV-2 vaccination? Or, was it after you were in a tick endemic area, or you physically pulled a tick off of your body, or, noted that there was a tick on your body? So exposure to the likely pathogen is what we look for when we're making the diagnosis. I also want to name the fact that there can be a lot of complexity going on. Someone may have sustained and survived a SARS-CoV-2 infection and felt mostly fine with something sort of smoldering beneath the surface. And then it wasn't until they went and had a SARS-CoV-2 vaccination that their symptoms really flared. Because one of the lead theories that we have for vaccine injury, which we're continuing to research, is that it is circulating spikes, circulating SARS-CoV-2 antigen that is causing problems. So it may be that no matter how you get that spike in your system, infection or exposure, it's the spike that is the problem. And so if you're an individual that is unable to clear the spike yourself, then, no matter how you get the spike, no matter what the source is, that's what's going to be your problem. And that's why we're very hopeful for monoclonal therapies and their promise in treating folks who may fit that phenotype. When it comes to things like chronic Lyme disease, what we are also seeing is that there may be reactivation of pathogens. And so a SARS-CoV-2 infection may bring a Borrelia infection or a Babesia infection or Bartonella. These are pathogens that ticks carry to the surface. So you may have had those in your system and been perfectly fine, and it wasn't until the COVID infection. So we try to keep an open mind, and we try to quantitatively test for as much as possible based on the symptoms that someone is telling us that they have.
How do we get past the roadblock of much of the clinical world not wanting to admit the impact of viral persistence?
There's a huge and a frustrating issue, and I think, for our part as a center of excellence for infection-associated chronic conditions and illnesses, we are aggressively, pushing to present science to policymakers and leaders to make it explicit that if you are one of these folks who are, for no good reason, I think it's really important for us to very strongly state the fact that if you're a researcher or a clinician who is saying that viral persistence isn't real in the case of long COVID or other infection-associated chronic conditions and illnesses, you really are speaking counter to the consensus science. We now have enough papers that have been published in the highest impact journals in the world showing that these are realities. These are not sort of theoretical or poorly proven entities. The viral persistence is real, and viral persistence certainly accounts for a reasonable proportion of symptom drivers in people with infection-associated chronic conditions and illnesses. So what we really need to do is get out there and educate. We need to show this evidence over and over again to people who are being critical of it or people who are just really oblivious to it. And we also need to get the government involved in making sure that people understand that, in many cases, if you're baselessly denying the existence of these concepts, there needs to be consequences for doing that, because you're being counter to the consensus science, and we don't allow that in clinical practice. And so this is no different.
Any experiences with the effect of pregnancy on long COVID and long COVID on pregnancy?
This is a great question, and we only have anecdotal experience in this realm, and the anecdotal experience is quite a challenging story right now. And what I mean by that is some individuals who have become pregnant whilst in our clinic have reported symptom improvements during some trimesters and symptom worsenings during other trimesters. And so we're really trying to understand how best to interpret that information and get a more coherent story as to the influence of hormones on long COVID symptoms. We do have a study that we're currently in the process of doing data analysis on, where we're hoping that either we're hoping to get the paper out in at least preprint, either Q4 of this year or Q1 of next year, where we show that certain hormones of ovulation significantly impact symptoms that people who menstruate are experiencing with their long COVID. So, we're starting to show relationships around cognitive impairment and luteinizing hormone, post-exertional malaise, and estrogen and progesterone levels. So as we start to clarify that story a little bit more, we're hoping that we can at least use that information to provide guidance to not only pregnant people, but also people who menstruate on how to plan through the severity of their symptoms, either through their cycle or through their pregnancy.
Spironolactone helps my long COVID. I'm not sure why. Is it an ACE2 thing?
Honestly, I think that I think that anything that can act on an ACE2 receptor is a credible theory for why it might be helping you. We haven't done too much on that particular compound, but it's something that I think we're definitely willing to look into and learn a little bit more about. But there is a lot of emerging literature showing that that compounds, supplements, medications that work on ACE2 receptor behaviors can be very, very helpful for long COVID because, of course, the ACE2 receptor is where the spike protein binds to.
As a core patient and a large advocate for the work you and the scientific community do, curious if there's anything I can do as a layperson to support your work beyond talking about it positively.
Oh, well, that's very nice, and I appreciate people talking about it positively. I do think that what we really need is coordinated advocating for government change. As a clinic in New York City, there's so many folks around the world and around the United States who are asking, can we come to core? Can we, how do we get this? How do we get care where we are right now? What is really clear to us is that the program that we're building needs to scale. And for that, we need government support. For that, we need funding support. For that, we need people to be aware of the fact that we're trying to create a program that can be scaled beyond us. We have no intention of being some sort of fancy destination clinic that only treats the rich and the famous who fly in from all over the world to see us. That's not who we are. That's not the behavior that we've set for any of our other clinics that we also run that don't treat long COVID and infection-associated chronic conditions and illnesses. So what we really need are people to get out there and advocate for the government to provide more resources to research, more resources to education, and more resources toward replicating clinical models that work and replicating clinical models that are covered by insurance, as opposed to people having to spend their life savings on trying to get help.
If we have LC and maybe from the virus and vaccine, do you recommend the flu shot?
So far, and again, when it comes to the intersection of vaccines and long COVID symptoms, we can only provide conjecture and anecdote. So far, the majority of our patients have not experienced bad effects from long-term bad effects from the flu. We do notice that there is a subset of our patients who take a little while longer to sort of recover from a flu shot. Just the immune activation itself makes them feel extra crummy for a few days. I think all of us, or most of us, when we take a flu shot, will feel a bit woozy and a bit off, for a day or a few hours. We see that exaggerated in a subset of our long COVID patients, where the immune activation from the flu shot might make them feel longer for a few more days. And so we tell people to plan around that. However, we do firmly believe, given the ability of the SARS-CoV-2 virus to suppress T cell function and cause problems with our ability to fight off and stave off infections, and of course, what I think everyone with lived experience will attest to, which is every time you get sick, it takes you longer to recover. You tend to get sicker than most people, and you tend to get sicker easier than most people. Anything that can provide good infection prevention results, like a flu vaccine, which, a flu vaccine will truly reduce your chances of getting influenza. We strongly recommend that.
Do you share your knowledge and findings with the rest of the world? I live in Europe, and I am wondering if our medical practitioners have the same knowledge as you.
Well, I would say absolutely. We're only a small clinic, but we're always spending a fair amount of our time working on education. I would also say that our lovely person who's reading out all of the questions is hard at work actually translating. And yes, we are working really, really hard to provide education as well. So a lot of our team are often spending nights and weekends speaking at conferences, speaking at conventions for physicians. And I'm so grateful for the whole team that, often doesn't get a lot of downtime, doesn't get a lot of rest, because that's exactly what they're trying to do. We firmly believe that the only way for us to move the needle on quality of care of people with infection-associated chronic conditions and illnesses is to get out there and educate the rest of the world, educate practitioners, because we can't do it all alone.
What about combination of several antivirals, bi or tri therapies?
Yeah, I think that this is crucial. Earlier this year, we published a paper in Lancet Infectious Disease, which is, a leading infectious disease journal. And the paper was led by our scientific director, Dr. Amy Proal. And we talked about this exact issue, that single antivirals are most likely not going to get it done for a lot of people who are experiencing viral persistence, as well as reactivation of latent pathogens. The literature tells us, and now we're borrowing from literature looking at things like HIV management. We're looking at literature borrowing from diagnoses like TB. The literature tells us that often with these conditions, not only do you need combinations of antivirals, but you need combinations of antivirals that last for a very long time, so that you're taking these antivirals over a long period of time, as opposed to a standard 2-week or 3-week course. And so we firmly believe that this is the case, and we've been a little slow to start some of the combination antiviral trials, because often when we're working with regulatory agencies to get permission to run the clinical trials, first we need to show that single antivirals on their own are safe, at the very least safe, to be used in a new diagnosis like long COVID. And then we can start to bring together combinations of the antivirals. And so that is, we're actually hoping that our first combination antiviral clinical trial, which will be a combination of Valtrex, which is a herpes virus medication, Celebrex, which is largely used as an anti-inflammatory drug, but actually has action against alpha and gamma herpes viruses, and then Paxlovid, which many of us will know is a drug for treating acute SARS-CoV-2 infection. We're going to combine all three of those, and that will be one of our first combination antivirals that we try.
When trials study neuroinflammation, does neuroinflammation include a condition like IIH? Confession, one of my post-viral surprises as an LC patient is a brand new IIH condition after months of daily headaches.
So when we talk about neuroinflammation, we do speak fairly broadly about neuroinflammation, and associated conditions. So yes, that does also include conditions like IAH, but I also do hope that in the future, as we go, and we're just starting to scratch the surface of this, I firmly believe that we do need to get a little bit more specific about neuroinflammation, how much of this is being caused by, for instance, an inflammatory response as a result of a reactivated pathogen like a herpes virus, or a persistent pathogen like SARS-CoV-2, which we have seen evidence from autopsy studies that it can infect neural tissue, and how much of the neuroinflammation is being caused by autoimmunity, which can also be triggered by SARS-CoV-2 infection, or folks living with ME/CFS who can experience autoimmunity. I do think that we need to get more specific and more targeted with our overall characterization of neuroinflammation. And that's going to come from better imaging techniques and better blood testing protocols.
Can you talk about if mitochondrial supplements are helpful for LC?
Yes, it's a great question. Again, we think that mitochondrial dysfunction is a significant driver of symptoms in a large percentage of people with long COVID. And there have been really good placebo-controlled, randomized controlled trials looking at mitochondrial supplementation and its effects on long COVID. And we have seen positive results. So, for instance, there has been a trial showing that combination of CoQ10 and vitamin C, which are, CoQ10 is something that supports mitochondrial function. Vitamin C acts as an antioxidant, which means it removes some of the waste products from the body as we're trying to sort of produce more energy. In combination, in a placebo-controlled, randomized controlled trial, this was shown to be helpful. Alpha lipoic acid is another mitochondrial supplement that has been shown in randomized controlled trials to be useful. Oxaloacetate is another mitochondrial supplement that has been shown to be quite helpful in open label trials, so not randomized controlled trials, but trials where people take the supplements. So there is enough evidence at this point to suggest that a subset of individuals do benefit greatly from mitochondrial support. However, we still believe that you need to understand why the mitochondria are under such strain. Is it that your body is pushed into an autoimmune situation, and so there's just chronic inflammation causing problems every single day that puts strain on the mitochondrial system? Or is it due to reactivated pathogens or persistent pathogens? Until you address those underlying issues, all you can do is keep feeding yourself mitochondrial supporters, and that's not always sustainable either financially or biochemically for a lot of people.
What therapies are you studying as far as antivirals for EBV, enterovirus, and other latent pathogens? Which do you think show promise? Moravir, remdesivir, etc. Thank you.
Yeah. So I think there's a group in the UK, University of Derby, that is just finishing up a remdesivir trial. So we are watching that one closely, and I would urge everyone to be watching that closely, because I think that it is a good medication that could have some potential promise. Our team has just recently released a preprint, which hopefully will be peer reviewed and published soon, that looked at a combination of Valtrex, Celebrex, and Paxlovid, or Valtrex and Celebrex on its own, with the mechanism of action that we were addressing multiple reactivated viruses with that combination of antivirals. And the pilot open label study went well enough that we are now working toward completing a placebo-controlled, randomized controlled trial, which, if everything goes as planned, we should be able to start in the beginning of next year. Our main delay on that particular trial is that with the government shutdown, we're not receiving approval from the FDA to initiate ethical approval of the study. So we're kind of in a holding pattern there. But that is an example of a trial that we think is addressing reactivation of multiple viruses. So the other thing that I think is worth mentioning is our antiviral clinical trial that we're running right now. That the link is in the bio for anyone who might be interested in joining if they're in New York. We use a drug there called Truvada, which is a repurposed HIV drug. And the reason we chose Truvada is because a series of MS researchers actually who are looking into the link between Epstein-Barr virus and multiple sclerosis are using Truvada as a powerful anti-EBV agent. And so Truvada is going to be one of the first drugs that we really get to take a look at, and whether or not it affects EBV titers over a long period of time.
To test tick-borne pathogens, which tests are more precise? Thanks for all. And another person added to that question, of those most precise tests, which are available in Europe?
Right. Okay. So in our clinic, we will tend to tick-borne testing. We could and maybe we should bring Amy Prohl on and do a live just focused on tick-borne testing, because we could be incredibly long-winded and boring about tick-borne testing for a really long time. But suffice to say, many of the mainstream tests really only test for a very narrow portion of the species of bacteria and parasites that cause tick-borne illness. So there are many, many different species of Borrelia, for instance. This is the bacteria that causes Lyme disease. But many of the sort of mainstream tests only test for one or two of those species. So if you're not, lucky enough to be infected with those one or two species, you're going to test negative. So we typically work with a company called MDL and a company called IGeneX to do the tick-borne testing that we need, that really is able to capture the broad range of bacterial species that can cause tick-borne illness. IGeneX has just become available in Europe, so I would say that IGeneX would probably be the one to go for. They have both an immunoblot test, which is really informative for identifying whether or not you're making antibodies against some of these pathogens across a large range of the species. And they also have something called a FISH test, which looks specifically for genetic material of the pathogens as well, which can really give you a clue as to whether the pathogen is active in your body.
Is it true that CBD blocks ACE2, or is it snake oil?
CBD does have actions on ACE2. CBD also has actions on the autonomic nervous system. And so I think that it is unfair to call CBD snake oil, given that there is a huge range of literature in showing positive effects of CBD on various different conditions. I think that some of the challenges that we face with the use of CBD tends to be that we have many cannabinoid receptors in our body. And cannabinoid receptors are typically the receptors that CBD binds to in order to produce effects on the nervous system that may actually be helpful to people who are living with long COVID and other infection-associated chronic conditions and illnesses. And unfortunately, depending on our genetics, the sort of proportion of cannabinoid receptors that we have in our body that it can differ from person to person. And so effects can be quite variable with CBD because of that reason. Effects can also be quite variable with CBD because not all CBD products are created equal. Some of the CBD products that are on the market have not been tested by third party. Some of the CBD products that are on the market can contain terpene from the hemp plant, and some of the terpenes, which are the sort of aromatic compounds of the hemp plant that give it the distinctive smell that it has, can also act in concert with CBD to produce an even more potent effect. So it's not that it's snake oil, but I do think that most likely some of the effects of CBD are not its action on the ACE receptors, but more its action on cannabinoid receptors and their control of the nervous system. But because it's a largely unregulated product, I think you need to be really careful with source. And I also think that, certain people just won't respond because genetically their receptor profile is just not that responsive to the product.
Any advice for long COVID patients who are reinfected? And are you looking at metformin for improving and or preventing long COVID?
Yeah, absolutely. People who are reinfected, especially folks who can tolerate metformin. I want to name that some people have terrible effects with metformin. They can have really severe GI symptoms, but metformin is one of the drugs that we have in our arsenal for when people get reinfected. It seems to speed up their recovery and help them avoid any speed bumps in the way. Some people with long COVID, even when they're not reinfected, actually respond quite well to metformin. So it's something that we do try, or some of our clinicians do try at the center. The other thing, and I am completely blanking on the name of an antihistamine that recently made it through a randomized controlled trial that has shown it's a nasally delivered antihistamine, so nasal spray, that has shown to both lessen the duration of SARS-CoV-2 reinfection as well as seemingly reduce chances of long COVID developing after SARS-CoV-2 infection, that we're now starting to, I know that our providers are now starting to provide at the center, prescribe at the center.
Is that azelastine or is that a different thing?
That is exactly what azelastine. Thank you.
Will there be any regular Core Sine conferences or meetings to stay up to date with new developments?
It is in our future to start thinking about conferences and how we can either contribute to existing conferences or have or stand up our own conference. So yeah, please watch this space. I do think that the answer is both. I do think that the answer is that we want to start a conference that will work with a series of well-vetted long COVID professionals and IACCI professionals to be providing good quality education, as well as, for the reasons I've mentioned earlier in this live stream, I do think that we also want to see the extent to which we can infiltrate other conferences of other professional societies and stand up long COVID content in those conferences, so that PCPs who may not actually think that it's necessary to go to a standalone long COVID conference can go to a long COVID session within their annual conference that they go to. And physiatrists and cardiologists, I think that taking both approaches is very important.
The Polybio conference is also coming up and you should register. We also have several people saying that they participated in core trials in New York and it was a wonderful experience for them. So
thank you.
Sign up.
To hear that.
Link in our bio. One person says, I was part of a 15 days Paxlovid trial, which made all of my symptoms vanish to then come back after treatment. What about combined antivirals for longer times?
I think this is a crucial question, and yes, per the Lancet infectious disease paper that we published earlier this year, this is exactly what we're advocating for, and we do know that there are certain doctors out there who are already starting to do things like combining a monoclonal like Pemgarda with multiple doses of Paxlovid. And I think that that's a really clever approach. I think that the idea of combining antivirals or monoclonal agencies that both work to reduce persistent pathogens but work with different mechanisms over longer periods of time, I think is not only does it make good sense from a mechanistic standpoint, but it's crucial. It is the thing that we need to do next.
Someone asked, does EMDR, eye movement desensitization, and reprocessing help?
This is a good question. There have not been any specific trials on long COVID and EMDR to date. However, EMDR is a very good therapy, evidence-based therapy for PTSD. And I can say that a large proportion of folks who come through our clinic and others have experienced PTSD and actually meet criteria for PTSD based on the screening tools and screening instruments that we use. Now, when it comes to many of the mental health diagnoses that can accompany long COVID and other infection-associated chronic conditions and illnesses, it's not that we believe that these mental health diagnoses are responsible for the symptoms that we're seeing, but allowing these mental health diagnoses to continue unchecked and uncontrolled certainly do not help your overall symptom burden. So my inference would be that if someone is suffering from long COVID and PTSD, EMDR is going to have a beneficial effect and help to lower overall symptom burden. And it's something that is relatively low risk and is worth a try.
With severe mast cell disease triggered by long COVID, how do we navigate vaccination when vaccines seem to trigger an MCAS flare or worsening of symptoms? I know this is a difficult topic.
It is a difficult topic, and when we're dealing with folks who have severe MCAS, it really does come down, unfortunately for us, it really does come down to personal choice of the person who is living with these symptoms. And I wish I had a better answer for you, then you kind of need to make this impossible choice between feeling terrible for a few days, even a few weeks, and getting maximum protection from some of the seasonal pathogens that are circulating in the air. But currently, I wish I had good answers for this, but currently we tend to sort of have people stack with mast cell stabilizers and antihistamines. So, famotidine is a big one for long COVID, especially. Allegra, quercetin, etc. And then do their best to take the vaccine on a day where in a period where they may not have a whole lot going on, so that if they are feeling poorly, they can stay at home and recover. But I wish I had better advice, but it really does come down to whether or not someone is willing to put themselves through that or not.
What testing exists right now for SARS-CoV-2 persistence, and how close are we to a biomarker?
Yeah, so commercially speaking, there's not a whole lot of testing that we have for SARS-CoV-2 persistence. I think that there are big limitations with the spike antibody test. I don't think that is a reliable marker of SARS-CoV-2 persistence. And as I mentioned earlier in the live stream, both high levels and low levels can mean different things about what your immune system is doing and how your immune system might be responding
to a persistent antigen. A couple of labs that are emerging, such as Infecto Labs. This is a group that does have some FDA-approved testing that looks at how T cells respond to SARS-CoV-2 and give you an indication of whether or not the T cells are very, very sensitized to the virus or not. Again, these are inferential, but meaning that the provider needs to look at that result and sort of think for themselves, hey, does this mean that this person might have persistence or not? It's not a hard and fast biomarker. But those are some of the sort of commercially available things. So they are imperfect and they require someone who's knowledgeable to sort of think about it a little bit. Coming down the pipeline, we have folks like David Walt, who has the Simoa assay, which looks for spikes circulating in the blood. This is actually a very sensitive assay, and it's quite good. It's quite accurate. And finding circulating spike in the blood could certainly indicate that persistence is at play. There are some who would disagree with that. There are some who would say, no, we need to be able to see the pathogen, doing its thing and dancing around under our microscope for us to believe that means persistence. But for most of us sensible people, if we're seeing antigen persisting 700 days after the last infection, it probably means that there's a persistent pathogen hiding out. That is the Simoa assay is a fair way away from being commercially available, unfortunately. But, this is, I think, if I were in charge of a big bag of government money, I would be saying that groups like this should be getting it so that we do have a biomarker sooner rather than later. I also think that there's a great researcher called Tim Heinrich on the West Coast who's doing imaging-based studies. So he's created, and he will be talking at the Polybio Symposium, and he's created some, wonderful radioligands that can bind to pathogens. And then when you go into a scanner, these sort of complexes between the radioligand and the pathogen that have bound together light up. So you can evaluate the whole body, which takes away the problem of, sometimes people may test negative for the plasma test, like the Simoa test, because the pathogen isn't in their plasma right now. But it doesn't mean that just because it isn't in their plasma, it isn't hiding in an organ or tissue elsewhere.
Is a nicotine patch really helpful in getting rid of the spike protein, long COVID, or ME/CFS?
Yeah. Nicotine has been a mixed bag in our anecdotal experience. No one's run a good study on it. There is one study that I have read that was on a very small N that did indicate that nicotine had potentially some not quite spike removal, but spike blocking potential, so stopping spike from binding with ACE receptors and other receptors, so stopping it from getting inside cells. It was really actually quite well done work. It was just such a small N that it's hard to judge, and it was in a dish as opposed to in a person, so it's hard to judge if this is actually happening as a physiological mechanism, or if the subset of people, and there is a subset of people who say that nicotine really made a big difference in their symptoms, if it's not just nicotine doing what nicotine does, which is firing up your nervous system and giving you a little bit more energy and pushing you forward. So right now, I would say the jury's out on nicotine. We need far more robust physiologic data to understand what nicotine is doing to spike.
Thank you all.
Thank you, everyone. Thanks for listening and great questions.
Yes.